Awesome, we're good to go. So good morning, everyone. Thank you for joining us today for our Health and Action work group. Chelsea Andrews and I are the site engagement coordinators for MVC, and we look forward to facilitating this work group today. So in recognition of Mental Health Awareness Month, today's work group will feature a presentation by Dr. Dalack and Carla Metzger of the Michigan Collaborative Care Implementation Support Team. Thank you for being here with us today, Dr. Dalack and Carla. Dr. Gregory W. Dalack is Daniel E. Offutt III Professor and Chair of the Department of Psychiatry at the University of Michigan. Dr. Dalack's previous roles include a variety of leadership positions in the mental health service at the VA Ann Arbor healthcare system, Associate Chair for Education and Academic Affairs for the Department of Psychiatry, Vice Chair of the Department, and Interim Chair until his appointment as Chair in 2010. Dr. Dalack is past President of American Association of Chairs of Departments of Psychiatry and received the AACDP Leadership Award in 2019. He also served as Treasurer of the American Psychiatric Association from 2018 to 2020 and currently serves on the APA Foundation Board. Dr. Dalack received his BS in chemistry at Yale University and received his medical degree from the College of Physicians and Surgeons of Columbia University. He completed his internship in medicine at the Presbyterian Hospital in the city of New York and his psychiatry residency at the New York State Psychiatric Institute. Also at Columbia and NYSPI, he completed a fellowship in psychopharmacology. Dr. Dalack has had research interests in the treatment of chronic and persistent mental illnesses, particularly focusing on schizophrenia.
Hello, this is Leticia Ruffin, social worker.
Hello, happy you're here. Over the past 11 years, he also has become involved in developing collaborative care programs to provide psychiatric and behavioral health expertise within primary care clinics. Carla Metzger has been working in behavioral health and integrated health for over 25 years. For several years, she has served as the clinical coordinator for the Washtenaw Community Health Organization, an organization that coordinated community mental health center services and publicly funded substance abuse treatment services for 5 Michigan counties. As part of her role at the WCHO, Ms. Metzger spearheaded several integration projects. More recently, Ms. Metzger also worked with the Center for Health and Research Transformation on a SAMHSA promoting the integration of primary and behavioral health care grant focused on assisting community mental health centers and federally qualified health centers to further integrate behavioral health and physical health care to improve patient health outcomes. Currently, Ms. Metzger is the program director for the Michigan Collaborative Care Implementation Support Team. Through collaboration with Blue Cross Blue Shield of Michigan, Ms. Metzger has overseen MCCIST as they roll out the collaborative care model throughout Michigan. MCCIST has provided collaborative care model training, technical assistance, and implementation support to over 300 primary care, pediatric, and perinatal clinics in Michigan. Thank you, Dr. Dalack and Carla, for joining us today for this work group. Before you begin your presentation, I have some brief housekeeping items to review. So first, this session is being recorded. The slides and the recording will be shared with attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We also will have some designated Q&A time at the end of the presentation. Lastly, your feedback is very important to us, so if you could please complete the post-work group survey in a link that will be provided, that would be greatly appreciated. With that, you are welcome to share your presentation, Dr. Dalack and Carla. Thanks for being here.
Had to unmute there.
Thanks. I thought I had before I went to share. So thanks very much. Are you all able to see my slide?
Yep, looks great.
So it's really a pleasure for me and for my colleague Carla Metzger to join you today to talk about a program that we've been very actively involved in going on almost 10 years now, and a chance to talk about an innovative evidence-based program that brings support to primary care providers and their patients for their mental health needs.
So a little bit about MSIS, the Michigan Collaborative Care Implementation and Support Team. So as Gregory mentioned, we've been around about 10 years. We provide clinical training, technical assistance, and at the elbow tailored consultation to POs and to clinics to not only successfully implement collaborative care, but also to sustain it. So we have over the years implemented in somewhere between 200 to 300 clinics. And those clinics range from everything from large healthcare systems, independent practices, federally qualified health centers, rural health centers. So really the whole kind of gamut of providers. We started out with primary care providers and pediatric providers, and now are moving into working with specialty care providers as well. So we don't just offer your typical kind of canned trainings. We also provide comprehensive implementation support and consultation, and really aim to help clinics and POs be successful in implementing the psychiatric collaborative care model with fidelity.
And I think that'll be an important part we'll be able to elaborate on later in the presentation. Just to level set, I'll spend a couple of minutes just talking about the large, overwhelming need for broader provision of mental health services in primary care settings. So as many of you are aware, depression, anxiety, psychiatric disorders writ large are highly prevalent in the population. About 50% of individuals will be diagnosed with a mental illness at some point during their lifetime, and about 25% of adolescents will have experienced depression by the age of 18. And we know that late adolescence, early adulthood is when the majority of mental illness first presents. The consequences of not addressing mental health issues leads to greater chronicity and also impairment of physical as well as mental health functioning and opportunities to participate in education and vocational activities later in life. And the medical costs for folks who have chronic medical conditions and unaddressed mental health or substance use disorder needs is quite high. So the medical costs for those folks are 2 to 3 times as high as those who don't have comorbid conditions. And if they're unaddressed, those needs end up getting met through ER visits in inefficient ways that lead to poorer health outcomes, general health outcomes, as well as mental health outcomes, and cost a huge amount for the country. We also know that access to mental health providers, including psychiatrists, is very, very challenged. And it is the case that many folks who primary care providers might want to refer into specialty care don't really want to go to specialty care, and some of them may not need to if they can access the level of care they need through their primary care clinic, and that's what the collaborative care model is all about. There are many ways to present the access challenges that we face. This is just one of them, that across the country, you can see by the majority of states being in red and only a couple being in a yellow color there are not enough psychiatrists to go around. I could say the same thing for psychiatric social workers, psychiatric nurses, psychologists, and there are not enough psychiatric beds to meet the need. And so a lot of effort goes into trying to meet the mental health need as best we can where it initially presents when possible. Not all patients who have mental health needs can have those needs met in primary care, but for those who can, the collaborative care model is really designed to try and support the primary care practice in meeting those needs at the highest level possible.
The next couple of slides will go over kind of the nitty-gritty of the collaborative care model, but it's just a brief overview. Collaborative care is the most evidence-based integrated behavioral health model. Not to say there aren't other integrated behavioral health models out there that exist and can be helpful, but collaborative care has over 90 randomized control trials. And those trials show that collaborative care provides significantly better behavioral outcomes than, quote, usual care. Collaborative care isn't new. It's been around a while. And as we know, it often takes a long time to get evidence-based practices into typical care. So the first big randomized control trial of collaborative care was published in 2002, and that was the IMPACT study out of the University of Washington. So as Gregory already mentioned, collaborative care is typically primary care based. You're really meeting the behavioral health care needs of the patient and their patient-centered medical home. This helps make sure patients don't fall through the cracks. It also decreases stigma because this is where patients are used to coming for their health needs. Patients involved in collaborative care, actually many can show improvements that compare to those who are actually referred out to and served by community psychiatry clinics. This model of care, which we'll talk about a little bit more, is the evidence-based is for persons who have mental health needs, primarily depression, anxiety, ADHD, that can be safely treated within the patient-centered medical home. It's not designed to meet the needs of folks who need higher levels of care, such as, say, community mental health, where they need wraparound services, or emergency healthcare needs. And as Gregory alluded, the return on investment, as published by several authors, including Jürgen Unitzer, report that the return on investment for collaborative care is actually 6 to 1. And I think Gregory also mentioned most of those savings are actually seen on the physical health care side of things, not the behavioral health end. So this is a bit of a schematic that tries to look at the collaborative care model. So as always, the patient is in the center of the model of care. The medical provider, the person who's typically writing the prescriptions, remains in kind of control of the treatment team. They're really continuing to make all of the decisions, but with the help of 2 new roles and 1 new tool. So the 2 new roles that we'd be introducing in collaborative care are a behavioral health care manager and a psychiatric consultant. So the behavioral health care manager is typically an MSW or a nurse. They're a licensed health provider, although they could be limited license. And we often say that they're acting as the quarterback of the team. They're really pulling everyone together. They're talking frequently with the patient, they're interacting with the medical provider, and they're sitting down at least once a week, typically virtually, with the psychiatric consultant. So this behavioral health care manager is acting as almost the eyes and ears of the psychiatric consultant. They may be delivering care virtually, or they may be embedded in the primary care office. But they're doing structured clinical assessments. They're using standardized questionnaires such as the PHQ-9 and the GAD-7 to assess and keep track of the patient's depression and anxiety symptoms. They're working with the patient to create self-management plans and also, as the patient gets better, relapse prevention plans. They're not only monitoring the patient and acting as the go-between between the medical provider and the psychiatric consultant, but they're also delivering evidence-based brief behavioral interventions. So they're not acting as a traditional co-located therapist. Their interactions with the patient after the initial assessment and the initial self-management planning stages are often brief, whether they be in person or over the phone. So they're interacting, checking on, meds, patient's improvement, and they're also delivering those brief interventions such as motivational interviewing, behavioral activation, et cetera. The behavioral health care manager is also responsible for keeping the systematic case review tool up to date. So this systematic case review tool can be embedded within the EHR or could be a standalone tool. There are several out that are commercially available, and then there are other homegrown tools that can be used. But at a minimum, the systematic case review tool will include information such as the patient's name, their identifier, the date they enrolled in collaborative care, their initial scores for depression and anxiety, their most recent scores for depression and anxiety, and can also include other information that are pertinent to the treatment team. But at a minimum, that's what we expect the systematic case review tool to include. And as I think I mentioned, at least once weekly, the behavioral health care manager meets with the psychiatric consultant. Now, the psychiatric consultant is typically a psychiatrist. They can be contracted by the physician organization or the clinic, or maybe they're already on staff in the clinic. But in this role, they are not actually seeing the patients, but they're reviewing that systematic case review tool with the behavioral health care manager. So they're looking at this case review tool, which may have anywhere from 20 to 120 patients who are currently active in collaborative care. They're discussing in depth the new patients who have enrolled in collaborative care, patients who aren't getting better, and patients who maybe are getting better and are ready for relapse prevention. They provide recommendations back to the medical provider and the behavioral health care manager on the patient's self-management plan and their treatment plan. So they may be recommending medications, at which point in time, like I said, they would not be prescribing those meds. They would be recommending it to the medical provider, who would then make the ultimate decision on whether to institute the treatment plan recommendations. If the medical provider agrees with the psychiatric consultant, which I have to say in the 10 years doing this, about 97% of the time they agree, they would then talk with their treatment team, and someone from the treatment team would call the patient or interact with the patient. Sometimes that's the medical provider. More often it's that behavioral health care manager who will be following up with the patient to discuss recommendations and then continue to follow up. Gregory, did I miss anything?
I don't think so. I may just want to emphasize one or 2 points. Appreciate the chance to do that. The behavioral health care manager is really the linchpin in this whole project and requires, for proper implementation, dedicated time to do this work. The psychiatric consultant is then able to partner with behavioral health care manager and bring in their expertise to the primary care practice and to the patients. And the behavioral health care manager does the close follow-up to make sure that med recommendations are being implemented. If the primary care provider agrees, the patient's taking meds, helps them figure out whether side effects are manageable or whether adjustments need to be made, and can bring in the psychiatric consultant. So it accelerates the care that primary care providers are often trying to provide in their setting, but didn't have the support to zero in on the treatment and move it along rapidly. As Carla said, the vast majority of patients, the psychiatrist never sees directly, but with the psychiatrist involved, it also allows them to facilitate stepping up care for patients who don't respond to the first, second, perhaps third intervention, or who have diagnostic diagnoses that require higher levels of care from the get-go, can move them and try and facilitate their entry into specialty care settings rather than sort of getting stalled in the primary care provider's practice. So I think we're going to try and show a brief video now, and I'll just ask my colleague to give me a thumbs up if everything sounds good here.
Millions of Americans struggle with mental health and substance use issues each year. But quality treatment can be difficult and expensive to access, often leading to a lot of unnecessary medical expenses if left unaddressed. We know that when accessible and done right, psychiatric treatment works. Many patients with mental health and substance use concerns talk to their primary care providers, or PCP, first. PCPs traditionally have had two choices: treat the issue themselves or try to refer the patient to a mental health provider, like a psychiatrist. Unfortunately, medical providers sometimes don't know how to respond or how to help patients access quality mental health care. In part, that's because there simply aren't enough mental health providers to meet the need of all the referrals. Wouldn't it be great if there was a way to get people seen that was timely, effective, affordable, less stigmatizing for patients, less costly for healthcare systems, and ensured access to psychiatrists who play a central role in providing effective, quality treatment? There is. The collaborative care model is a way to provide psychiatric services in the primary care setting. The collaborative care model has a rich body of scientific evidence supporting its efficacy. How does it work? The cornerstone of the model is a behavioral healthcare manager, a mental health professional who practices right in the clinic with the primary care team, ensuring accessibility. This care manager works directly with a consulting psychiatrist who provides the expertise to keep treatment on track and who is available to offer support on cases that need extra help. The model uses procedures for assessment and treatment that have been proven to work. It's an organized approach that ensures patients receive the most effective care and no one falls through the cracks. Treatment can include focused talking therapies and medication when indicated that's prescribed by the PCP and overseen by the consulting psychiatrist. This model makes quality mental health care more accessible to more individuals across the country. Seem too good to be true? Collaborative care is happening right now all over the country, and it's reimbursable by insurance. Psychiatric treatment works, and the collaborative care model helps more people access it. With this model, providers can focus on what they do best: help people get better. Interested in learning more? Visit psychiatry.org/collaborate for more information.
So the American Psychiatric Association has made a very big push to provide training for psychiatrists in this model and to try and help primary care practices connect to psychiatrists around the country who have trained in this model as well, recognizing that the need is out there and that there will never be enough psychiatrists or mental health providers of any discipline to meet the need. So I just want to emphasize that the components of the collaborative care model as we're presenting it here is patient-centered and meets the needs of the patient in the medical home and tries to improve the care provided in the primary care setting so that the patient gets the right care in the right place at the right time. It's measurement-based care, so it's treatment to target. We closely follow PHQ-9 and GAD scores, can use the registry to flag patients who are not progressing to figure out whether that's an issue with adherence to the treatment or a treatment not working and needing to get adjusted or changed in some way. And we're able to change the treatments until the goals are achieved. And if we feel like the person isn't responding after several adjustments and changes and adherence is good, then the chance is to step up their care. And often the behavioral health care manager and psychiatrist can facilitate that. It is population-based care in that patients who are in active engagement are in the registry, are tracked. It helps us not lose track of patients because we can flag, talking about a patient that we initially discussed today in 4 weeks or 5 weeks, 6 weeks, and make sure that we have a kind of a holistic view of the care. The evidence-based care is also there as well. Carla talked about brief psychotherapeutic interventions, medication interventions, the combination of the two, and also the planning for relapse prevention. So as a patient improves and stabilizes, they get moved to discussing how to recognize warning signs of recurrence, what to do to maintain the gains that they've gotten. And it allows the care to be accountable care, in which the providers remain accountable for the quality of the care and the clinical outcomes. And as was mentioned in the video presentation, there are now codes that can be billed to generate revenue for this form of care into the primary care clinics.
Gregory just talked a little bit about relapse prevention plans. So within collaborative care, relapse prevention planning is standard, and collaborative care is flexible enough that patients can come in and out of care as needed should they notice signs of relapse. So the behavioral health care managers typically complete these relapse prevention plans with all of the discharging patients. Patients are an active part of creating those plans. These plans document the warning signs, what's the treatment plan going forward, what's worked for the patient, what hasn't worked, what they found to be their best coping strategies, who are their support systems, and who do they call if things are not going as well as how it had hoped and they're worried about relapsing. Their goals are measurable. So in those self-management and relapse prevention plans, they were really looking to empower the patients and to create a shared document for the patient and the treatment team to reference. And this is a living document. It typically is entered into the EHR, so everyone knows kind of what the plan is, at least for the moment. Long-term outcome improvements have been shown to that patients are significantly improved for quite a while. We know at least for 6 months, and the evidence base is also showing that patients who have been in collaborative care and have truly engaged in collaborative care show significant long-term benefits for up to 5 years. And the data just hasn't been followed longer than that to show, to look at what even farther longer-term outcomes might look like. So collaborative care is a bit of a lift for some practices, more so for some than others. It truly is a practice transformation. Collaborative care is really a team-based approach to providing good clinical care for patients. For clinics and POs that are looking at implementing collaborative care, we really team with them to look at their current and existing clinical protocols and to kind of rework them as necessary. You really need to look at how you're going to be training your behavioral health care manager and your psychiatric consultant to provide quality collaborative care. This isn't the model of care that many behavioral health folks and psychiatrists were initially trained at. There's lots of training efforts going on right now, both at the APA, through Blue Cross Blue Shield of Michigan, and with other training organizations throughout the country. We really need to orient primary care providers to their new role within collaborative care, that they're not necessarily referring out all of the patients that have behavioral health needs. For some of those, they're keeping them in their practice and working with their behavioral health care manager and their psychiatric consultant for good long-term outcomes. And as I mentioned, reviewing and adapting the clinical workflows is critical, looking at who is referred to what levels of care, how you document, how you monitor, and how you're following up with your patients. Collaborative care requires, for some clinics, a cultural transformation and really trying to engage providers and get this buy-in for a team-based integrated care model. Some clinics are farther down the road. They've already done this, so this is a little bit of a tweak for them. For others, that cultural transformation is more of a lift. Technological adaptations are required for collaborative care. You're going to have to develop some sort of that systematic case review tool, that population health patient registry for collaborative care. Ideally, that's integrated into your EHR. For some clinics and for some systems, that's not easy or possible. So when we're working with clinics and POs, we work with them to explore all of their options. And some can be pretty simple, depending on what is available and possible within your clinic or system. We also provide documentation templates and work with your EHR folks to adapt EHR documentation to support not only the clinical communication, but also the billing practices. And there are two major staffing requirements, and Gregory alluded to this. It's really important to train up a behavioral health care manager and protect their time to be able to effectively do this work. We have seen many times where the collaborative care work, the behavioral health care management work will be added on top of an already overworked, say, social worker, nurse care manager. And that simply won't work. If they have not enough time to carve out to do the work, that's great, but they do have to have the time to do the work. And then finding a psychiatric consultant to work with you. We have been lucky to train up quite a few psychiatric consultants, and as Gregory mentioned, the APA is also doing so. So that's been very helpful, but many practices don't have that relationship. So we do try to get them as much as possible hooked up with a psychiatric consultant who's trained and has worked in this role.
And I would just add that not every social worker or nurse is cut out to do this work, and not every psychiatrist is cut out to do this work. I went through my own sort of cultural change, moving from a traditional practice, which I still have to a small extent, into doing psychiatric consultant work. And it's a different feel. The teamwork is really important. The trust of the behavioral health care manager and the relationship with the primary care providers is really key. And not everybody wants it or is able to adapt and make that change. So it's important to make sure that the person is right, the time is protected, and the training is meaningful. So again, just to emphasize, what sets this apart from other models? So it's a population health approach. The systematic case review tool is really important for tracking outcomes, making sure you're not forgetting folks who you talked about a while ago. It sort of allows you to bring them back up by tracking whether their scores have improved. It's proactive, tailored outreach by the behavioral health care manager, which allows for monitoring adherence checks in between primary care provider visits. It's important to have the psychiatric consultant and the behavioral health care manager work well and be trained in this manner. And we also track how often contacts are being made to make sure that the touches are there, to make sure that patients are moving along in their treatment to target goals, with the opportunity during the panel reviews to adjust those treatments and check on how well they're coming towards the goals. It does allow us to talk about and address the care needs of many more patients than I am able to do sitting one-on-one in my office. So talk about 6 to 8 patients reviewed per hour as opposed to 1 patient, maybe 2. And it helps reserve the specialty clinic time for the cases with higher needs, whether that is known from the beginning for folks with more severe psychiatric disorders presenting in primary care, or for folks who haven't responded to sufficient collaborative care interventions. And it means that the patients that the primary care provider refers into this get talked about and recommendations made usually within a week, which is a very, very fast, much faster turnaround time than we can usually promise in the specialty clinic. Carl, anything you want to add there?
No. So as we may have stated at the very beginning of this presentation, our team currently is partnering with Blue Cross Blue Shield of Michigan in this in a collaborative care PGIP initiative. So for POs and clinics that decide to engage within this PGIP program, we provide training, and not just training, but at the elbow, virtually, implementation support. We currently are training to work with the adult population where the vast majority of evidence bases. We also train clinics to work with adolescents in collaborative care, where there's a robust and growing evidence base. And we recently started to work with OB-GYNs and family practice to work with perinatal folks who can be served within the collaborative care model. And we're looking at other subspecialty populations to engage in the future. So for POs and clinics that decide to engage in this PGIP project, there are pretty robust PO and clinic incentives, both monetary and value-based reimbursement on the E&M codes. And if your EHR does not and cannot support the systematic case review tool, Blue Cross Blue Shield is paying POs to purchase, at least for the first 2 years, the AIMS caseload tracking tool to use for that purpose. So we have been very grateful to the support of Blue Cross Blue Shield of Michigan. They've really been passionate about implementing collaborative care to better meet the needs of patients and providers in Michigan.
So we have a couple of testimonials, and I think just given the time, we'll show this one, which shows implementation and some feedback from the providers about collaborative care. So bear with me while I pull this up.
Life is stressful, and the depression and anxiety that often comes along with it can be debilitating. That's why practices like Bronson Internal Medicine and Pediatrics in Kalamazoo are implementing collaborative care, an innovative program supported by Blue Cross Blue Shield of Michigan that treats the behavioral health needs of patients in their primary care physician's office.
I believe it's beneficial to patients because it is conducted within their medical home in an environment that they are already familiar with and trust in.
There's been a drastic increase in the need for mental health services, both for adults and pediatrics. It's a huge benefit for the patients because this is often a time where they feel very vulnerable. I think it's also really beneficial for psychiatry resources because it means that the psychiatrist gets to spend that in-office time with the patients who are more severely ill. So I think it's kind of a win across the board for everyone.
Well, hi, how are you today?
Behavioral health specialist Kimberly Baker shared one patient's success story. The woman struggled with depression and anxiety for more than 20 years.
And really didn't know that life could be better than what she was already living. She decided to join the program, and in 8 months, she is now in remission. She says that doing this program has made me more comfortable in opening up about issues and concerns. I am proud of myself and how far I have come after being miserable for so long. I am very grateful that I accepted the opportunity to do this.
With the help of the psychiatrist in the collaborative program, we were able to pick a different medication for her, which has really improved her symptoms. I also think having regular contact with the social worker and having that frequent support was really helpful to her as well. I think she is a great example for how this program can really work to support people and help us get to our goals a lot faster.
To find a primary care doctor that participates in collaborative care, go to Find a Doctor on bcbsm.com. For more information on collaborative care, visit bcbsm.com/behavioral-mental-health.
Okay, I think, are we going to try one other?
Yeah, let's go for it.
Okay.
Care has transformed the lives of our patients. Simply said, without collaborative care in our office, many of our patients would be falling through the cracks. And so we're very, very fortunate to have this functionality in our office. What's really been wonderful is we were one of the first sites to start collaborative care roughly about 8 or 9 years ago in the academic internal medicine office with the forward thinking of Kristen Spangler and the IHA practice. It has really moved forward in remarkable ways. I think that this improves the ability to support patients with behavioral health care needs right at the point of care. We literally can take a patient that's in our office, and the physicians that are seeing that patient can then hand that patient over to our collaborative care, our behavioral health care team right in the office. And so that's been a remarkable asset for our patients. Moreover, the communication from the standpoint of communicating with the psychiatrist and then getting that information back to the doctor that is the primary care doc, that has really revolutionized the ability to kind of not have patients fall through the cracks. I think that in regards to recommending collaborative care, it's a no-brainer. It's one of the most valuable assets that we have in our office at the Academic Internal Medicine office. Care has transformed the lives of.
Right. So again, just on behalf of Carla and myself, we really appreciate the chance to talk with you about this. We both are pretty passionate about this work and feel like it's really important and supporting our primary care colleagues, but also meeting the behavioral health needs of many more patients than would traditionally have their needs met in kind of the traditional style or old style of providing that care. So we appreciate the opportunity. Carla, I'll let you make some closing remarks, then we have a chance for questions.
I think you covered most of it, Gregory. Again, thank you. If anyone is interested in learning more about collaborative care, please feel free to reach out to our team. I think these slides will be going out to folks, so you will have our contact info. And again, we appreciate your time.
Thank you so much, Dr. Dalack and Carla. That was a great presentation, really important work. So now we have some time for questions. Does anyone have any questions for Dr. Dalack or Carla?
Hi, everyone. Leticia Ruffin, social worker at MSU Healthcare. I had a question. You mentioned that you provide some support for us to get started.
So Blue Cross Blue Shield of Michigan, we engage with Blue Cross Blue Shield and the physician organization. So typically we would meet with the physician organization, learn what their needs are, learn what their clinics need. Blue Cross Blue Shield of Michigan, should POs decide to engage within this PGIP initiative, they provide monetary assistance, and then we as the training partner provide training, implementation support, and typically work with POs for up to around 6 months. Some stay with us longer, some stay with us shorter. And then there's a nomination and designation process that is built on that's kind of based on capabilities that Blue Cross Blue Shield requires. And should POs and clinics nominate the clinics for designation, if they meet all of those capabilities, then there is a VBR uplift for clinics who have successfully implemented collaborative care.
Trying to take as much notes as I can.
And like I said, if you forget things, if you want more details, just reach out to us. And definitely. I see Lindsay West is here with us today too. She is with MICMT, and MICMT provides some overarching project and management and administrative support. So MICMT is also another gateway to get more information.
And thanks, Carla. I am dropping into the chat then just our direct link to the co-care page that highlights one of the testimonials that Dr. Dalack shared, as well as additional information and further context as well for MSIST. Thank you, Lindsay.
I have a question.
I just had a quick question. What electronic medical record are you using, Dr. Is it Dalack?
Yeah, Gregory. So we
Gregory.
are on an EPIC system at Michigan Medicine, and we're fortunate to partner with our information technology team to build a registry into the EHR. As Carla mentioned, there's various approaches, and there are freestanding elements as well, or registries as well, or systematic case review tools. Obviously, having it integrated is really good because we can look, I can write my notes to the primary care providers, I can review other notes that are there and check scores and all of that. But we're in an EPIC system. What are you on?
Here at MSU, we're on Athena. I'm familiar with Epic from my previous jobs, and yes, I do enjoy Epic. But here at MSU, we have Athena. We are working with some of the designers. I met last week with 2 engineers to try to figure out a way to incorporate behavioral integrated model for the notes and all that, where you've got to schedule 3 people and to be in the same area at the same time. So we're working on that, but I'm sure it's a ways away. I'm a social worker and not a data person, so I don't know how it really works.
Yeah, me neither. So that's
Yeah.
why we have those teams working with us. Absolutely.
Yeah. Thank you for telling me what you're on. I'm just trying to take notes because yes, this is coming down the pipeline. I'm excited. I've been in mental health for a long time, so I'm glad we're going to be doing it here at MSU.
At least one of our past clinics, was able to build the systematic case review tool in Athena. And there are standalone registries that actually integrate with Athena and other EHR platforms. So,
do you happen to know the name of that PO? Just so that we can have like someone to
they have
collaborate
actually
with.
moved. Unfortunately, they have actually moved off of Athena, and their builder has left. So I would give you the name, but it's not going to be helpful at this point.
Okay. Thanks.
There's a question in the chat. Does the initiative help find an available psych provider?
I can answer that if you like,
Go
Gregory.
ahead, please, Carla.
So we have trained a number of psychiatric providers, and we in the collaborative care model, and we do have I think it's on the MICMT page. I'm not sure if Lindsay's still here. Lindsay, do we still have a short list, or where does that reside?
I'm sorry, I missed that one.
That's okay. At one point, go ahead.
Oh no, a psychiatric list?
Yes.
I hear that. Yes, let me grab that for you. Yep, we do have that.
And there are other telemed providers that are moving into this sphere of collaborative care also. We're seeing kind of a plethora arrive. And Gregory, I don't know if the APA has a list also, or are connecting people. I know they've done a lot of training in this.
Yeah, I can't speak exactly to that. I know they have trained folks. Whether they keep that as a data repository and are able to let you know who in your area might have been trained is a good question. That would probably require reaching out to the APA directly to understand that. Obviously, as this happens, as this disseminates more, there are psychiatrists in many parts of the state, that are incorporating this as a part of their work. And hopefully through the MICMT website and the Blue Cross Blue Shield initiative, it's possible to network and figure out what might be possible in your area. They don't have to be in your vicinity directly, right? Because this can happen virtually. I mean, even at Michigan Medicine, the work that I do is virtual, meeting with the behavioral health care manager and for our weekly meetings. And I've done my panel reviews all over the country if I'm traveling. So it does provide that sort of flexibility as well.
I did share the link to our psychiatric resources, and we have been instructed that you can just outreach to them directly via their email listed.
Thank you.
I'm seeing the question, would a psych NP or a psych PA also work? If they have the appropriate training and are trusted and by the team, a psych NP can definitely provide collaborative care. If you're billing Michigan Medicaid at this point in time, a psych PA cannot be the billing provider, or a psych PA cannot be the psychiatric consultant for billing purposes. But as far as we know, that's the only major payer in Michigan that has that stipulation. But there may be other payers. Sometimes it's payer specific.
And that was the Medicaid?
Michigan Medicaid, yep.
Michigan Medicaid.
All of the Michigan Medicaid health plans.
Okay. I know when I was in the ER at Beaumont, I worked with the psych PA and PO, PA and NP. So, but in the ER, they billed. So I just wanted to know. Thanks.
I would also just say, because this is care at a distance, you do want to make sure you have somebody who is seasoned, if I can use that word.
Yes.
This wouldn't be a right out of your training kind of job to put somebody into, because there is a certain amount of just being able to hear and collaborate and ask questions that sometimes you need the underpinning of a fair bit of patient care and exposure to feel comfortable doing.
I have a question. I know you guys have spoken a lot about like reimbursement and support at that level, and just regarding the visits and follow up with patients between, in person versus the telehealth. Have you run into or heard of any challenges with reimbursements regarding like the telehealth visit side of things with the collaborative care model, or is that not something you guys have really heard much about?
Actually, the way CMS defined the codes, and there are 3 primary codes for collaborative care and 1 G code for FQHCs, it specifically states that away from the patient care counts towards the billable minutes. Now the patient has to, for Michigan Medicaid and some payers, the patient has to have been seen in the office by the primary care provider within the last year. But as far as delivering the care indirectly, we haven't seen any difficulties with that. There is some language in CMS that the behavioral health care manager has to be available to meet in person with the patient. I'm not sure how, we do know that some POs and clinics are providing solely virtual care, and we haven't heard of any difficulties with that, but we do recommend that everybody talk with their billing specialists and refer to the CMS guidelines and MLMs.
Great, that's great. And that would cover like phone calls and like virtual
phone calls, care management activities that are clinical in nature but don't involve the patient. It all goes towards these monthly billable minutes that are needed to bill the collaborative care codes.
That's fabulous. Thank you. That's very helpful.
So that is another beauty of collaborative care. You are able to bill for time that is not traditionally billable in traditional behavioral health care. And the codes are actually coming from the physical, the medical physical benefit, not the behavioral health benefit.
Right. And the panel review also counts into that time, cumulative time spent on patient care as well. And so the psychiatrist is not billing separately. This is just a bill that goes from to the primary care, from the primary care practice to the insurer for that time spent, and then contracted separately for the psychiatrist's time.
Thank you.
Great questions.
I have one last question. I know that we're getting on time, but looking at the collaborative care treatment team, I do see that there are community-based services noted. Do you have any example of how like the collaborative care treatment team has worked with like a community-based organization or a community-based service, just to kind of give an example to that?
Yeah, I can give a couple of examples. For instance, when the behavioral health care manager is doing their assessment, they're also looking at kind of all of those social determinants of health issues also that may provide challenges to the patient. So they may be, say, for an elderly patient, referring to Meals on Wheels or other support services. And in some cases, not all, but in some cases, the patient might benefit from a course of an evidence-based therapy that isn't typically provided within collaborative care. So when it's clinically appropriate, a patient could be referred out to, say, a therapist for, say 6 to 12 sessions of say cognitive behavioral therapy, and they'll remain in collaborative care at the same time with the behavioral health care manager, kind of liaisoning with the therapist to make sure that the treatment remains coordinated and that they're not kind of double dipping or doing the same things with the patient. And then when the patient successfully or however the patient ends treatment, they can finish up their course of collaborative care as appropriate. Gregory, any thoughts?
I agree with all of that. Very often we have patients who have experienced traumatic events in their lives, and that informs their presentation. And sometimes it's beneficial for them to engage in a treatment that is more focused on that. That's outside the scope of what the behavioral health care manager will do in depth, but sometimes that's felt to be needed. So trying to facilitate their connection to that. And again, this may be something that's been a part of their history forever, but they've only now in this setting had the opportunity to talk about it or bring it up and then get connected to resources as well. We have a pretty extensive time-limited group program at Michigan Medicine. And so a number of patients with anxiety or depression will sometimes be able to access those groups without seeing a psychiatrist in the clinic to be able to augment the briefer treatments that the behavioral health care manager might be doing as well. And then in addition, as Carla said, trying to help patients address the social determinants of health, which often there are social workers in the clinic also engaged in. And so there's a partnership there as well in trying to make sure that those needs are met for patients, which are fundamental to their overall health and their ability to participate in care to the best extent they can.
Great, thank you. Okay, so with the interest in time, we close up around 12. So I just have a few housekeeping items to kind of finish up the work group today. Thank you again, Carla and Dr. Dalack, for being here with us today. That was a really, really informative presentation. As a reminder to everyone, this presentation was recorded and it will be posted on our YouTube channel. If you'd like to share it with any of your colleagues, we also will be sharing the slide deck in an email following this work group. So I'm going to go ahead and share my screen again to just do some closing remarks. Can you see everything okay? Mm-hmm. Okay, awesome. So for some upcoming events, I did want to note that we have a diabetes work group scheduled for May 23rd from 2 o'clock to 3 o'clock p.m. And that is going to feature Deborah Dillon from Sparrow Eaton Hospital and Melissa Mays from the Sparrow Diabetes and Endocrinology Clinic. Additionally, I wanted to make note that we have our MVC Spring Collaborative Wide Meeting, and that is going to be on May 19th from 10 o'clock to 3 o'clock p.m. at the Vista Tech Center in Livonia, Michigan. The last day to register for this event is tomorrow, May 12th. So we encourage you to register if you have not already done so. This spring's meeting will focus on interdisciplinary collaboration, care transitions, alternative sites of care, and success stories from MVC's 10 years of partnership with healthcare providers. Lastly, we will have a health equity work group in the beginning of June on June 7th from 1 o'clock to 2 o'clock p.m. And that is going to feature Thomas Pierce from University of Michigan Health West. So thank you again. Thank you to our presenters. Thank you to our attendees for being here with us. If you have any questions, please don't hesitate to reach out to us at our email listed here. Additionally, going forward, if you or someone you know may be interested in speaking at one of our work groups, please contact the MVC engagement team via this email. Thank you once again for your support of MVC, and we look forward to seeing you at future work groups. Have a great day, everyone.